All right, good morning, everyone. Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractic physician at Gates Brain Health. And today we're talking about preventing depression in kids, or how you can approach depression in kids from a natural perspective. And so you can see our PowerPoint here. For all of you on Facebook, just know that you can watch the YouTube version live right now, or we're going to post the YouTube version because we have a PowerPoint that's screen and screen. So you can watch that at around 8 a.m. So we'll have it on there. Okay. So preventing depression in kids. So what I see in my practice a lot is that I have a lot of patients who have depression and anxiety. The story is that for years I was treating patients who had fibromyalgia, and in doing so, a lot of them had comorbid depression and anxiety. As years went on, it seemed like I was getting referrals to work with patients for that. I'm not a psychiatrist, but people in my experience may have a stigma about taking something like an antidepressant, or they may not want to engage in something like talk therapy. Not everybody, I'm just saying the people coming to me. And so in doing that, I started working with individuals from a neurotransmitter perspective, so in supplement perspective, as well as addressing the functional correlates of the microbiome and food sensitivities and Hashimoto's. And then I started having patients who were having improvements. And so it became very exciting. So that's kind of how I got here. And as I started helping individuals, particularly mothers, with depression and anxiety, then it started turning into more and more individuals saying, okay, well, can you help my kid? Because I'm worried about my child developing depression, or they're already, manifesting symptoms of anxiety. And so that's what we're talking about this morning when it comes to disorders of mood and anxiety. So just for everybody who's watching, and good morning to everybody, is that here is a little piece from the Principles of Neuroscience. I'm bringing a lot of figures in from that book just for everyone to look at. And this is their DSM-4 criteria basically for diagnosing depression. The DSM-4 is the standard manual used by psychiatrists in the American Psychiatric Association to say what is depression, or what is ADHD, or what is schizophrenia. It has since been replaced by the 5th version. This is from the 4th version, and basically the nuances are very similar. So to be diagnosed with depression, an individual has to have had a depressed mood and or loss of pleasure. The depressed mood has to have been present for about 2 weeks, and it has to be most of the time. And oftentimes, as you can see here, individuals will say, I feel sad, or I feel empty, or other people will be saying, Johnny appears really tearful. Or the individual will be saying, I just don't have any interest in doing anything. I'm not finding pleasure from the things that I used to have enjoyment in, so they're not enjoying playing soccer or things of that nature. And then they have to have at least 4 of the following. So they can have changes in their weight. Usually around 5% of their body mass will change. They may have insomnia or hypersomnia nearly every day, so meaning they're sleeping too much, or they're not sleeping enough. And they may have psychomotor agitation or retardation, psychomotor retardation. So what that means is that the individual may be really fidgety, or that's psychomotor agitation, or they may not have any energy to move. So they're glued to the couch, so to speak. They're in their bed. Putting on their clothes is just so much work. Combing their hair is nearly impossible. That's psychomotor retardation. They may have fatigue or loss of energy. And so a lot of individuals, for example, just a little timeout, who have chronic fatigue will basically go to their doctors and they'll say, I'm fatigued, and their doctors will say, you're depressed. This is why, because as doctors are trained, doctors get a lot of training in psychiatry when they're going through their residencies. And so if a person presents with fatigue, lots of times if you rule out something like cancer or a thyroid problem, the next thing a doctor is going to think, well, is this person depressed? This is why. And I have other videos discussing at length how to differentiate between just chronic fatigue, not just, but chronic fatigue and depression. Okay, going on, feelings of worthlessness or excessive inappropriate guilt. So people who feel really guilty and they can't get off of, well, I said this to so-and-so 2 years ago and I feel like a horrible person about it. They can't let it go. Those are referred to as perseverations, more commonly referred to as ruminations. They heavily relate to serotonin issues. Diminished ability to think or concentrate, or indecisiveness, such as trouble thinking. Recurrent thoughts of death, and this is one of the more serious ones, suicidal ideation, where individuals don't really want to live anymore. Do they have a plan for harm? That is as urgent as a heart attack, and that's why a lot of doctors are perceived to overreact, but basically it's the current medical ethical understanding that if somebody is presenting saying they have a plan to harm themselves, you have to basically send the person to the emergency room. So that's major depression. And then going through also bipolar disorder, manic episodes are important to be aware of. These are individuals who have reduced, just out of nowhere, they have reduced need for sleep. So they may have a period of depression followed by a period where they wrote a book over a weekend, and they have an inflated view of themselves, and they may have delusions where they think, well, I'm the next Nostradamus, and I'm not being funny. I mean, literally, there's an inflated view of someone's self-esteem or grandiosity, as it's referred to. They may be talking a lot. They may have trouble concentrating. And there's a lot of discussion about how individuals who go on to develop bipolar disorder, which more commonly presents in the 20s, may have had attention deficit disorder as a child. Doesn't mean all people with ADHD are going to develop bipolar, not by any means, but distractibility, poor attention is a piece of manic episodes. Increase in goal-directed activity, so they're really focused on work, excessive involvement in pleasurable activities that may have a high potential for painful consequences. So maybe they're going out and buying 3 cars in a weekend, or engaging in promiscuous activity without thinking of the consequences. Those are manic episodes. But what I want to highlight with major depression is that about half of people who have depression develop a major depressive episode when they are in childhood. So that's important. So half of people who are going to have a depressive episode, which if you look at the entire population is about 16 to 17% of people by current estimates. Half of them are going to have an episode before the age of 25. So this is why it's important for parents to be vigilant and recognize this. Again, for all of our Facebook followers, this PowerPoint will be presented on YouTube, and we'll repost it to Facebook. So this is a recurrence risk ratio, and this is also important because we talk about genetics a lot, and lots of times people think genetics are destiny. Other people ignore genetics. It's really a middle ground. So, for example, schizophrenia is one of the most highly studied psychiatric conditions as it pertains to genetics, because throughout the years, researchers and just everybody has observed that there tends to be a family preponderance. And so, for example, let's say if you have a sibling with schizophrenia, you have a 9% chance in essence of developing schizophrenia. If you have a twin from the same embryo, you have a 48% chance. So it's about a 50% chance. So what can we infer from that? Basically, you have a 50-50 chance of developing schizophrenia if you have a twin with it. That says that yes, there's a genetic predisposition, but there's a lot of environmental factors. Particularly, you see that if it's a sibling, the rate goes down to 9%. So for something like schizophrenia, that occurs in 1% of the population. So if you just take a random study, irrespective of familial issues, basically you're going to see that everybody has 1% chance of developing schizophrenia. So a sibling has a 9% chance. Bipolar disorder also occurs in 1% of the population. And if you have a sibling with bipolar disorder, you have a 7% chance of developing bipolar disorder. That's interesting because it's not a 70% chance or 80% chance. It's a 7% chance. So certainly genetics are at play, but they're not the whole factor. And with major depression, it goes down even farther. If you have a sister or brother with depression, you have a 2 to 3% chance, in essence, a recurrence risk ratio of developing major depression. If you have an identical twin, 16%. So I think that's good for everybody to see, because even though your dad's depressed, it doesn't mean that you're going to develop depression. But it's something to be attentive to, because you may not have depression, but you may have more periods of dysphoria where you have low mood. You may be more susceptible to stress, facets such as that. Here, this diagram was presented in our last broadcast on stress and addiction, overlapping pathways between stress and addiction and stress and depression. Again, the amygdala, which is your fear center, is right next to your memory area. This is a frontal section of the brain, this one that I'm highlighting here. And so your memory area is one of two areas of your brain. I say it every week, every broadcast, one of two areas in your brain that makes new brain cells all the time. About 700 new brain cells a day should be formed in your hippocampus. Your amygdala, your fear center, which is right next to it, has the potentiality to enlarge and actually take over the neurological real estate of your hippocampus. That's why stress management, monitoring our thoughts is super, super duper important. And this amygdala really connects into your anterior cingulate gyrus. This is our emotional part of the brain. If you've heard the term limbic system, your limbic system is your cingulate gyrus, which borders the white structure here, the corpus callosum. Out here is your dorsolateral prefrontal cortex. You have, on the undersurface, you have the lateral orbitofrontal. Excuse me, I probably should use some water. Drink some water. A lateral orbitofrontal cortex, and here you have your medial orbitofrontal cortex. Okay, so this is again talking about metabolism in the anterior cingulate gyrus. Basically, they see that people who have more activity in the anterior cingulate gyrus tend to respond better to antidepressants. And this is again the diagram of the nexus of what I talk about every week, because it's so important. The more your amygdala is activated, the more signals it sends to your hypothalamus, the more cortisol you produce. The higher cortisol that's produced feeds back into the brain, and it literally, as I'll go back up to the other diagram, kills brain cells in the hippocampus. More brain cells fried in the hippocampus typically results in a depressive phenomenology, or it actually may manifest as anxiety to begin with, which later becomes depression. So what does this mean? Let's just pause for our youth. So I was doing some research this morning, and basically we would all like to think that depression is more common now than it was, let's say, in the 1950s. That statement is true. Ironically, depression was not more common as of the year 2000 when I graduated high school than it was in the 1960s. So we would say from the 1960s to 2000, the depression estimates were actually pretty similar. Certainly there's a lot of methodological issues where back in the 60s, doctors were more likely to diagnose anxiety than they were to diagnose depression. And they used more terms like neuroses at that time. But with the advent of antidepressants, then depression became a more commonly used term. Bottom line, though, is that depression estimates were pretty similar for that period of time. However, out of Columbia University, they found that from 2005 to 2015, the incidence of depression, particularly in youth, went up precipitously. So this will likely resonate with many of the people watching this. Our society has changed since the year 2000. What's happened? Well, the internet came out. Smartphones came out when? Around 2007, I believe, was when the first iPhone came out. 2006. I remember being in school at that time, and people were walking around with the new iPhone. It was such an amazing thing. And now in 2020, almost invariably, most people have smartphones, and those who don't, I admire them because they seem to have a simpler life. So now we have our devices, and all we can say is that depression has increased in the last 10 years. What's going on? Food supply has changed. Social media has changed. Instant gratification has changed. And as you've heard me talk in other broadcasts, I'll keep going back to reference frames. This is something that I have to remind myself, I have to remind my patients. We all have to keep in mind that we have a map of every part of our body in our brain, and we actually have a map of what we think our life should look like. So, for example, in this region through here is where we have maps of different body parts. Whereas here, particularly through this region, they have shown that we have almost like a map of what we think our relationships should look like, what our job should look like, what our spiritual life should look like, versus reality. What does it look like? And when there's a discrepancy there, which can be referred to as an error signal, that can result in activation of the anterior cingulate gyrus right here, called the subcallosal anterior cingulate gyrus, i.e. our SAD area. So something to be very attentive to. And one can argue, this is completely conjecture, but it's worth a debate. Let me know what you guys think. I would love it if you post it to YouTube and Facebook. That basically pre-internet. The internet I know came out in the 90s, but for example, when I graduated high school, we got a computer lab where the internet was widely used. That was around the spring of 2000, or maybe even fall 1999. So there wasn't a lot of internet usage going on. So before 2000, life, we could say, maybe was more tranquil. Families came home, they had dinner, they sat and talked to each other. Even if the kids didn't want to talk, like my dad would ask me how my day was, and I'd say, it's fine, pass the ketchup. Needless to say, we were sitting there and we were talking, whereas now everybody is on their phone, swiping up, and we're lost in this sea of looking at other people who seem to be having phenomenal times with fantastic lives and beautiful places. So one could say that maybe now we have more reminders on a daily basis throwing in our face of maybe how we're not adding up. And is that relating to adolescent depression? Possibly something to be aware of for kids who are maybe suffering with anxiety and depression. And I would say in that situation, getting them in with a psychologist or doctor hypnotherapy, I think is very important, because that's a situation where I've seen really good changes to help people with coping strategies. There's a time and a place for everything, and I'm certainly in favor of those disciplines because they can help people to get better coping strategies for their lives, to say, hey, just because Janie is off in Hawaii having a great time with her family, and your family hasn't been on vacation, doesn't mean that you're bad. It means this, it means that, help you with this, help you with that, so on and so forth. Okay. Going down through the PowerPoint, and I have to give homage to Melanie. Melanie put together another great PowerPoint. Thank you, Melanie. I hope you all are liking this new format, because it's pretty cool because you get to see in more detail what I'm talking about. This is a diagram of monoamine transmission. What are monoamines? Serotonin, norepinephrine, and dopamine. These are monoamine neurotransmitters. A lot of people say, well, most of serotonin is produced in your gut. All the functional medicine people out there, functional medicine tribe, totally with you in so many regards. But keep in mind, while serotonin is produced in the gut and is pivotal for gastrointestinal motility, serotonin is produced in the brain. It's produced in the nucleus magnus raphe complex. You have a rostral raphe nuclei and you have a caudal raphe nuclei, basically demonstrated here. Looking at a frontal section of the brain, you can see this cluster of nuclei running up and down through the brainstem. Largely in the pons is where it's commonly referred to, but you could probably say pontomedullary reticular formation here as well. So magnus raphe nuclei produce serotonin. That serotonin then has projections to many parts of your brain. You can see that. Serotonin is referred to as a positive chemical, helps us not to have things like OCD, helps with anxiety, helps with perseverations, that guilt that I was talking about. Here's a diagram of norepinephrine. Norepinephrine largely is produced from many areas, but the locus ceruleus is one of the most commonly referred to areas. Keep in mind that these chemicals, including serotonin, go up and they go down. So you see this diagram going down, it goes down to the spinal cord, helps with shutting off pain. Just a little tangent on fibromyalgia. Fibromyalgia patients tend to feel things at a higher level than people without fibromyalgia. There's many reasons for that, but one of the first mechanisms discussed was that they had poor serotonin metabolism here because of lack of sleep, and because of that, they weren't shutting off pain signals coming into their body. You're probably not feeling the shirt on your back right now or the blanket on you. It's because you have serotonin and norepinephrine running down your spinal cord to shut off unwanted stimuli. Okay, so there you have norepinephrine. And then they didn't really diagram dopamine as well. I don't think I have dopamine in here, but your dopamine comes largely from your your ventral tegmental area firing into your nucleus accumbens. We talked about that last week with addiction. This is just a diagram to say, okay, here's a brain cell, here's a brain cell. You have these water balloon-like things, like Dr. Sapolsky will say, that then get vomited out here, vomiting out serotonin or norepinephrine and dopamine that bind to receptors. These receptors tend to activate this brain cell here, and lots of times it can activate genetic, basically the production of different proteins and what's called G-coupled mechanisms and calcium calmodulin. if it's glutamate, to basically get brain cells stronger, producing more proteins, et cetera, et cetera. Now, this is just these are called second messenger systems. I'm not expecting any of you to grab onto this, but just know it's not just super simple like sodium coming into a brain cell and potassium going out. Lots of times these transmitters bind and they cause our DNA to produce proteins. Now, this is just a diagram of the fear center being activated when people are seeing scary faces. And this is a receptor for GABA, which is really important for things like anxiety, and drugs like Xanax, Ativan, Klonopin bind to this receptor. So let me see here. Oh, I can't see all of that. But what I was trying to talk about here is includes MTHFR polymorphisms. MTHFR stands for methyl tetrahydrofolate reductase. It's a really important thing to look at with any kid who has depression. Why? As I talked about a few weeks ago, because if you are homozygous for one variant called the C677T, your MTHFR activity can go down to 21%. If you have low MTHFR activity, you can't make monoamine neurotransmitters. You can't make serotonin, norepinephrine, and dopamine as well as other people. And the studies are definitive that if you combine an MTHFR polymorphism with stressful life circumstances, then one's chance of developing more frequent depressive episodes throughout their life goes up considerably. One study basically found it is somewhere between, like, if you have an MTHFR issue, homozygous, and stress, you're going to probably relapse into another depressive episode at 160 days approximately. If you don't have an MTHFR polymorphism and you haven't been exposed to like post-traumatic stress, then it goes up to the order of like 800 days for your next chance of relapsing. So genetics are really important, and this is where it ties in. Again, genetics are not destiny, but if you're a mom with depression, you worry about your kids, be very cognizant of what expectations your kid has on their life, what stresses they're putting on themselves, academically, sports-wise, socially, and then also be looking at their genetics. We do genetics here, genetic testing at Gates Brain Health, have done it for a while, and it's really important to look at if somebody's not responding to depressive treatment. Why do I not always do it? Because the tests are not necessarily cheap. But when it comes to kids, lots of times parents are willing to invest so we can get more accurate data as to how their brain is making serotonin, norepinephrine, and dopamine. Also looking at someone's COMT status. You may have heard me talk about that. COMT basically breaks down dopamine and norepinephrine and adrenaline. COMT is an enzyme that does that. If you have a slow enzyme doing that, you're going to have higher adrenaline, dopamine, and norepinephrine. Basically, they've shown that when that happens, the fear center enlarges in these individuals who don't break down dopamine and norepinephrine and adrenaline in the right hemisphere. Whereas when people break down dopamine, norepinephrine, and adrenaline excessively, the fear center tends to be smaller in the right hemisphere. So that can actually change the way your brain is wired, the way your brain architecture actually displays on a volumetric MRI. That's important because a lot of patients who develop a depressive episode have a period where they're actually anxious before they became depressed. So looking at genetics, and that's just two examples. There's BDNF, there's glutamate metabolism, there's how your brain processes different antidepressant drugs. So if you're looking on ongoing antidepressants, we can now say, oh, well, your liver's gonna process this drug really fast or really slow. So it's helping the accuracy, so to speak, of treatment for these conditions. Really important things to look at with kids. And I've worked with kids where we get their MTHFR status and I refer them to a doctor of hypnotherapy or a psychologist, and all of a sudden their depression goes away and they feel really good. That's hugely important for a kid because you're talking about a brain that's developing. And the more you can mitigate the amygdala enlarging and the hippocampus shrinking, the better of a job I feel you're doing to help the neurological health of that child. So just something to be aware of. Again, looking at your child's genetics, looking at your child's stress patterns and the pressure they're putting on themselves academically, sports-wise, and socially to help them in their brain development and for their fear center not to be excessively enlarged, I think is really, really important. And we need to discuss this Send me your comments, send me your feedback. I'll get back to all the questions on Facebook as soon as I'm done here. But yeah, that's kind of the point of today's broadcast. Going to follow up with anxiety. We're talking more about anxiety on Saturday morning. Again, the whole COVID-19 pandemic is going on. A lot of people are really scared for a number of reasons. And so we'll be talking about not only anxiety relative to COVID-19, but anxiety in general. So for those of you who want to, like our YouTube channel for Gates Brain Health, share this video, subscribe, all those things that I'm supposed to say. And we will say thank you for listening, and we'll talk to you later.